Yet I'm going to talk about the emotional impact of thyroid disease and thyroid eye disease, because I find that that's an area where there are a lot of questions and the medical system doesn't quite have too many answers. You'll find out today, and probably through your readings, that the surgical science for treating thyroid eye disease is advanced remarkably. You can do things through small incisions that virtually disappear, that are quite effective to reconstruct the face, the eyes, the orbits, improve eye alignment, improve the appearance, improve eyelid function, and even eliminate compressive optic neuropathy, which is the blinding disease that is associated with this process. You'll also find that we've gone through really incredible medical advancements in our understanding of the disease, and we've identified smoking as a risk factor. We've identified not only hyperthyroidism, but also hypothyroidism, especially after you undergo treatment for hyperthyroidism. If you end up becoming hypo, your eye disease may progress. And that may happen 10, 20 years later. You stop taking your Thyroid for whatever reason, and suddenly the eye disease can get revived. So a lot of understanding of the medical aspect and the surgical aspects of how to manage this disease. Yet the emotional aspect of this disease is something that really nobody studies. Yet I think that all of us in this room recognize that it's there. And our loved ones know it as well. Maybe though they can get very frustrated with that because they don't completely understand it. So my goal here is both to speak with patients who are going through the process, but also speak with loved ones, families and friends, and the support group who may say, it used to be different, and what happened. So let's talk a little bit about the thyroid hormone itself. Thyroid hormone, which is generated in the thyroid gland, is actually a transcription factor. It regulates gene expression. It both activates and represses genes throughout the body, from the brain to your toes. It controls metabolism. It's involved in the circadian rhythm. It's involved in the emotional centers of the brain, the amygdala. It's involved in how our other hormones function, including insulin, which is one of the reasons why we think that insulin and insulin-like growth factors may be actually involved in thyroid eye disease and thyroid disease. They have receptors in the skin and interact with skin. They interact with all the things that vitamin D does, which is it's important to make sure that your vitamin D levels and all your other health situation are stabilized when you are diagnosed with Graves' disease, because thyroid hormone interacts with all these things. It's involved in fertility. It's involved in bone growth. It's involved in virtually everything that is just a routine part of our life. The regulation of thyroid hormone is very complex. So in the thyroid gland, the pre-hormone gets iodines added to it. It's really the only tissue in the body that has high concentration of iodine. And then a pro-hormone, T4, is released into the bloodstream. The active hormone that regulates gene expression is T3. The liver does a lot of the conversion from T4 to T3, but also every tissue in the body potentially has the ability to convert T4 to T3, as well as degrade T3 to the inactive T2. And so your steady state levels in the bloodstream don't necessarily reflect what's going on in different tissues. I'm telling you all that in order to emphasize, and I'll get back to it in a moment, that when things change with thyroid hormone, it's like getting a train moving. And when you treat the disease, the train doesn't just stop. There is inertia to the disease, including the emotional inertia, which is where a lot of it gets manifested, that can last for months and years afterward. And this is all completely biological, and when you add to it the disfiguring and the visual debilitation and the double vision and all of that that goes on with thyroid eye disease. And what you end up getting is something that's really, really tough to do for everyone. So I'd like to start with a couple of anecdotes of stories, and I know that we're behind, so I'll be brief, because I'd like to get questions. But I'll share with you stories of two patients. The first is a 38-year-old man, and he was working in a warehouse, had a good job, good pay, good health insurance, did well, got along with his friends and colleagues, and had a good life. And then over the course of a year or so, his colleagues, by the time I saw him he was 38, this all started when he was about 36, he became more and more erratic, became confrontational, started being accusatory, couldn't follow through on projects that he used to be able to manage very easily. He would get easily distracted. If you confronted him about what he was doing, he would lash out. He became more and more physically engaged, even violent. And then after multiple warnings, he ended up attacking his boss. He was fired. No criminal charges were pressed because he had been there for 15 years and people just didn't understand what in the world was going on. But he did get fired. He lost his health insurance. And then he started feeling really, really bad dry eyes. And then he developed a little bit of double vision and got into a car accident. Now he had no health insurance, but it turns out that he was a veteran. And so he got plugged with the VA system and got sent for an evaluation. And by then, his eyes were crossing, his eyelids were retracted, his eyes were beginning to bulge, and the doctors in the VA suspected thyroid disease. They tested his blood. Sure enough, he had Graves' disease. He got radioactive iodine, and his eye disease went from moderate to really, really bad, vision-threatening, severe eye disease over the course of 2-3 months. Now, his emotional state going through this is horrible. It started out as horrible, and now you're adding the fact that he is in pain constantly in pain. Normal people like me, I don't feel my eyes. When I blink, I don't feel them. When I look around, I don't feel them. I don't feel my eyes. They're just there. People with thyroid eye disease feel their eyes all the time. It's like people with headaches. I don't feel my head. People who have chronic headaches always feel their head. That's not normal. It changes how you live your life minute to minute because you feel your eyes. He's in pain. People look at him as if he's crazy because he's got this crazy look. You know, we all, I don't know if you've seen Young Frankenstein, the person who played the servant did have thyroid eye disease. That did no service to the world of thyroid eye disease patients. Okay? Because the stigma is pretty significant. So you have the stigma associated with thyroid eye disease. He's basically unemployable. And so he is in my office crying, saying, you know, I'm not even 40 years old. My life is over. I can't get a job. I can't get a date. I can't get anything. I don't have health insurance. I'm in pain. I'm losing my vision. I'm going to go blind. I can't try. So that's one story. We did take care of his eyes. He lost a lot of vision in one eye, but we were able to bring some of it back. On the other side, we were able to bring all of it back. Eliminated his double vision. And he was able to get back into the workforce and resume his life. But that said, he's still traumatized by everything that he went through. And he's still more on edge. And some of that, the biology of it, you don't completely understand, but there is a train that leaves the station and you can't ever completely quit it. So, That's one story. Another is a girl who is 17 years old when I meet her. When she was 15, she started to behave erratically. She started skipping class. She started smoking cigarettes and hanging out with the wrong crowd. Her mom took her to the doctor, to the pediatrician. What's wrong with me, girl? She used to be a wonderful student and a wonderful daughter, and the pediatrician said, teenage girls. But it kept getting worse and worse. She started doing drugs. She started stealing from her parents. At 16, she ran away from home. And she was diagnosed with bipolar disorder, manic depressive. She was put in lithium as part of some court order because she was getting caught in criminal activity. The lithium did nothing, absolutely nothing. Then people noticed that her eyelids were beginning to look funny. And so that's how she ended up coming to me, because I see kids with thyroid eye disease. And I wrote a letter to her pediatrician and psychiatrist after checking the thyroid level, which was sky high. She does not have bipolar. She never had bipolar. She has thyroid disease, Graves' disease, and thyroid eye disease. And she is in the room crying, accusing me of wanting to kill her because I'm telling her to stop smoking, and siding with her mom. And her mom doesn't know what to do anymore with her daughter. They're not really even speaking to her. She's just a driver because her daughter is not allowed to drive. Anyway, she had her thyroid removed by thyroidectomy by Dr. Miller, who's speaking downstairs, about a month and a half or 2 months later. And after a series of reconstructive surgeries on her eyes, she now looks normal. She finished school with GED. She is now doing community college, getting ready for nursing school. And she's just a completely normal person. She still has the emotional toll, but she and her mom have patched things up. She lives out on her own. She works. She sees her family regularly. And now her mom is the one crying because she has her daughter back, and she's very happy about that. That said, the girl is really aware of everything that had happened to her. She now has insight, whereas before she didn't. And she tells me, I'm not like I used to be, and I don't know how much of it is because last time that I felt normal, I was a kid, and now I'm a young woman, and there are things associated with that. And I went through this thing, and there are things associated with that. And I can't really separate them. They're all part of who I am. And she'd like to go into healthcare because she thinks that she can bring a lot of her experience to patient care. So I told you these two stories, not to scare you or anything like that. You know, most of you can probably relate to some aspect of this. You know, it's heart-wrenching. And it's a part of thyroid disease and thyroid eye disease that doesn't get funds from NIH for research. And psychiatrists who are mostly psychopharmacologists don't have drugs for this. Insurance companies do not cover therapy usually. I think maybe more so today, but for years that wasn't the case. And there is an element of it that deals with self-worth and self-identity and self-image that the reconstructive surgery that Dr. Douglas will talk about in a little bit, I think, does impact on it. And we do see that getting back into normalcy is helped a lot by addressing the ophthalmic manifestations, the appearance and all of that. But it doesn't cure it. There is still a lingering effect of the emotional. And the most important thing is to really recognize that, realize that you're not alone. I hope that all of you have a chance to interact with one another and share your stories. We do have a patient who's later on going to talk about her story. You're not alone. What you have is not abnormal. It's very normal. And when you're struggling, talk with your doctors. I'm not a therapist, but I have been known to talk with my patients about things that are outside the immediate purview of oculoplastics, if I think that that's going to help. So that's very brief, but does anybody have any questions?
Yeah, we have some time for a few questions before our next speaker.
When you have those surgeries, how many do you have to have to get the eye set back? And how many does it take usually?
So Dr. Douglas is going to be talking about that. It's really, so one of the things that they started by talking about, which is the surgical advancements, we can tailor the reconstructive approach to the patient in ways that we couldn't before. There's really not a good answer because it depends. And to pigeonhole each patient into, okay, it should take you 3 surgeries, 7 surgeries, 10 surgeries, 1 surgery, I think there's a disservice to the tailored care that surgeons and patients need to discuss that is really focused on what the patient is looking for. So.
I'm curious, you mentioned with the young girl that they, before realizing that she had the eye disease and Graves' disease, had put her on lithium,
Yes.
and that didn't
No.
affect anything at all. I'm just curious, with all of what you mentioned, which seems fairly typical, is there, is this not treated by some of the mainstream antidepressants, et cetera? I mean, do any of those actually help,
Great
given
question.
the...
Yeah. So lithium specifically doesn't work because this is not bipolar. And the emotional ups and downs, you first of all have to take care of the underlying endocrine problem. That said, the lingering issues that go on with depression, with anxiety, with agoraphobia, I don't want to be outside because I look different, people are going to think that I'm weird, that I'm crazy, etc. All of that, standard psychiatric treatments are very effective for. And you do need to find a psychiatrist who is knowledgeable and willing to work with you, because it's not quite standard depression, because it's not like you don't have energy. You actually have energy, but there are cyclothymic elements to it that you need to get through. And I'm not a psychiatrist. I'm well read in this for an oculoplastic surgeon, but I'm not a psychiatrist. What I wish that there was more is therapy. And because insurances are not eager to cover therapy, because they don't completely understand benefits and things like that, and it's expensive, the way that therapists get around it is with group therapy. And I think that group therapy, especially for thyroid patients, can be wonderful, but you do need to seek it out. And oftentimes it's not popular.
Take one more question.
Sure. Is it safe to say then that a patient with thyroid eye disease will need to have any surgery?
No.
No.
So again, it depends. There are patients who have eyelid retraction, but they can close their eyes fine. Their eye discomfort is manageable to them. And I talk with my hands. And so they are fine just following regular appointments with their ophthalmologist to make sure that there's not some loss of vision, slow, gradual loss of vision, that by the time you feel it, it's too late. But other than that, lubrication, punctal plugs, supportive care is really the mainstay of treatment for most patients. It's only the patients who have more severe care or more severe issues where surgery becomes necessary. And again, it's not necessarily all or nothing. Maybe you need just a decompression, maybe you just need strabismus surgery, maybe you just need eyelid retraction surgery.
And can you give me an idea on a scale, if you will, when the patient's in the active phase, from beginning to middle to end, where you might be on that scale?
So in terms of determining where a patient is, when we see patients, we see them, they're often referred from other eye doctors or endocrinologists or their primary care doctor. So part of understanding where you are in that active phase is getting a good history from you. So understanding when did these symptoms start, how did they start, what started first. So for some people, they're like, my eyelids just started opening more. Whereas some people are saying, you know, my lids started getting a little swollen. So we take a history from you to try and understand when the symptoms that would be consistent with thyroid eye disease first began. And then you could have had those symptoms, you could have been in an active phase, and then when you see us, you may be in a stable phase. But one of the tools that helps us figure that out is that we see you, we evaluate you serially over time. So the first time we see you, you may not be active. You may be red and irritated just because you're so dry, your eyes are so dry from them being open so much. But the important thing for us is to see you at that initial visit and then see you again and see how things have changed. If nothing has changed in our measurements and your eyes are red just because they're dry, then more likely you're in a stable phase, but you have, you know, dry eyes, you may have congestion, which also makes your eyes red and your eyelids swollen. But it's really understanding how things are over time that helps us figure out whether you're active or, you know, in a stable phase. If you're in the active phase, like I said, most people have an active course for about 1.5 to 2.5 years, but not everyone falls in that range. Some people can be a much shorter time span, some people longer. But it's really based on the history that you give us in our exams over time.
What things are going to happen though as it progresses?
So as it progresses, there's just variability. So there may be variability in how swollen your eyelids are, how red your eyes are, your double vision. Some people say, you know, my double vision used to be really bad, or I used to have double vision, but now I don't have it so much. I only have it when I look up and not straight ahead. So it may wax and wane. For some patients, as muscles expand and get larger, if that's the way your disease is progressing, you may notice your double vision gets worse, or you may notice a reduction in your vision. So it varies per person and how your disease activity is, but those are the changes that might happen. I also wanted to speak to your first question about surgery and does everyone need surgery, and I agree with Dr. Kahana, not everyone does need surgery. If you have vision-threatening disease, then we will recommend surgery, or if your eyes are really exposed. But there are patients that we see all the time that they've changed, their looks have clearly changed, but they don't want surgery. They're just not wanting to undergo a surgical procedure, and I think in that case that's perfectly fine. It's always your decision. If you're losing vision or if there's something threatening your vision, we will definitely want you to have surgery. But I would also say the converse is true. Patients who have even mild changes in their eye when they don't have vision-threatening disease, often they're told by people, they come to us saying, we've been told there's nothing that can really be done for us because we're not losing vision. But they've changed. They don't look like themselves in the mirror. They want to look like the person that they used to be. And I think one thing that's great about the University of Michigan is I think that all of us recognize that. And so even if you don't have vision-threatening disease, we still want to try and help you, if you choose, to get back to the way that you used to look. And so, because that has a huge psychological impact as well, as Dr. Kahana just mentioned. So
It's the difference between cosmetic and reconstructive. This is not cosmetic surgery. It's reconstructive, trying to get you to a point where people who look at you don't think you have thyroid disease.
I just think also adding to that, the notion that the earlier you catch, whether you're treated, or brought to find a community like this, the earlier the disease process is caught affecting your eyes, the more they're able to help you.
I think that's true, especially with our improved understanding of the role of stabilizing the thyroid gland, working with our endocrine and surgical colleagues to get the disease under control as part of the overall reconstructive effort. And I know Dr. Husseini will be talking about that.